Good morning. Okay, I'll try Afrikaans. Goeiemorgen. Oh, bonjour. Okay. Thank you very much for inviting me. I thought I needed to refer back to how the world looked like in 2000 when we met. MDGs were adopted in the Millennium Summit, but at the time the cost of treatment of ARVs was $10,000 per person per annum. But there was also legal action in South Africa against President Nelson Mandela, initiated in 1997. But there was also lack of commitment to treatment, and there were also fewer people on treatment in South Africa. What it would have looked like today if that persisted and if nothing happened, in today's costs for the South African people, the 3.4 million people on treatment, it would have meant, that is if the $10,000 was still the case, it would have meant South Africa would be spending $34 billion. But that would have meant also the 3 times the current health budget would have been allocated for treatment, which is about $11.3 billion. But that means we wouldn't have had more people on treatment. There wouldn't be money for other services or salaries. Neither would there be money to run the health service. But I'm pleased to say that the landscape has changed. But what changed? Following the adoption of the TRIPS agreement, I think there were debates about the interpretation of the TRIPS agreement. In 2001, the Doha Declaration was adopted by WTO members. And I just want to highlight the 2 specific sections. One is that the members of WTO agreed that TRIPS does not and should not prevent members from taking measures to protect public health. They also affirmed that agreement can and should be interpreted and implemented in a manner that is supportive of WTO members' right to protect public health and in particular promote access to medicines for all. But we saw other developments in that between 2003 and 2004, there were establishment of international and multilateral initiatives, the emergence of Global Fund, PEPFAR, CHAI in 2003, WHO pre-qualification, which contributed towards ensuring that there were quality medicines available. But there was also another process which is never discussed or referred to, and this is the US FDA tentative approval. I thought I should mention it because it would never have been expected that the US at the time would have approved generic medicines for purposes of being used elsewhere in other countries. So in conjunction between the pre-qualification and US FDA tentative approval, we saw a lot of generic entry in some countries. But we also saw the Commission on Public Health Innovation and Intellectual Property come up with its report to see the nexus between public health, innovation, and intellectual property. 2006 was when the UNAID, an innovative financing mechanism, was established by, and I would say an innovative financing mechanism because it's based on airport tax, established by Brazil, Chile, France, Norway, UK, and others. What change also did this make treatment affordable? WHO also had a landmark decision about the global strategy, plan of action on public health, innovation, and intellectual property, which actually has 8 elements. 8 elements that looks at how innovation can be promoted, research and development can be prioritized, and also how innovative capacity can be built, particularly in developing countries. It also looked at what access barriers were in place, whether regulatory, administrative, technical, and otherwise. But following that, there was a consultative expert working group on research and development. This was mainly to look at how research and development could be financed, particularly for medicines and other products that are needed to treat diseases that disproportionately affect developing countries. And I must say that that was not all. In conjunction, we've seen a solidarity amongst funders, development agencies, countries, but we've also seen advocacy among civil society, change in approaches by academia, as well as the private sector response and other governments. In South Africa, we've seen the benefits. The benefits have been that 3.4 million people were put on treatment. That has had a major impact in that we've seen an improving life expectancy from 58 years in 2009 to 62 years in 2014. I would like to quote Slim Karim. He says it's not common that you see increase in life expectancy over a short period. And I say we've seen it in South Africa. But also we've seen a decline in AIDS deaths from 410,000 in 2008 to 180,000 in 2014. We've also seen mother-to-child transmission reduction. At 6 weeks, we've seen it drop from 8% to 1.5% in 2015. But because we want HIV-free survival at 18 and 24 months, it is not enough to just establish whether transmission rates have dropped at 6 weeks. We'd like to see whether those babies are still HIV-free and that they survive and they are healthy at 24 months. So more studies, you must have heard from our MRC colleagues that some of these studies have been conducted. But we've also seen market impact. We've seen competition landscape changed in that because of early generic entry, there was competition, and competition drove prices down. But we've also seen financial impact in that there was a reduction of prices of ARVs by 53%. But that was not all. More recently, we've seen a 40% reduction of viral load, and for us, it has been quite a significant impact because it means that not only are medicines affordable, but also the diagnostic test. And I've asked the question, is the glass half full or half empty with these developments? Personally, I'm an optimist. I think it is half full. But the future may also not be so secure. Globally, we know that 37 million people are HIV positive. We have 17, you probably heard this repeatedly. But we also have children, 3.3 million children that are HIV, and 32% only receive treatment. So it means we need some innovative approaches on how we can get access quicker. We also need simpler formulations, not for adults only. Children are not young adults. We need appropriate, age-appropriate regimen for children. But just as a reminder, we've got the terrible twins, the deadly duo of HIV and TB. TB remains a killer. 1 in 3, we know that it causes deaths in 1 in 3 AIDS-related cases. To address HIV-TB combination and reach the UNAIDS 1990 targets require of us to really take a hard look of our response, particularly with regard to access to MDR and XDR TB treatment. Early access to ART also saves lives and reduces the risk of TB. Undiagnosed or untreated TB worsens and accelerates HIV projection. Now, children must not be left behind. Pediatric ARV market has no incentives for industry, but purely because it's complex. It's a very complex market with different strength and dosing per weight band. But in 2015, we saw that there were quite a number of children on treatment, but more also need treatment. But we still need to ensure that there's access to vaccines, even in emergency situations. I want to cite an example of West Africa when there was Ebola. It cannot be that as we deal with Ebola, as we treat HIV, we forget about access to vaccines. So only 370,000 of children with TB on treatment out of an estimated 1 million have access to appropriate treatment. So we have to address this. There is also a growing burden of NCDs. In South Africa, I call it colliding epidemics of HIV, TB, and NCDs. So as we deal with reduction of HIV treatment and TB, we must also address reduction in cancer medicines. Gaps remains, of course, but I think this is a journey, and in any journey, we have to prepare, we have to find solutions. I'll focus for innovation on 3 particular areas. 2 new drugs to treat TB have been developed, first in over 50 years, and some have been conditionally approved. Firstly, let's use the FDA tentative approval to fast-track approval in least developed countries with limited capacity, and even in some of the middle-income countries. Secondly, for antiretrovirals, for second and third line, let's see, as more people are put on first line, the risk of resistance increases. Let's make sure they are affordable and they can be accessed. Antimicrobial resistance is a concern. It's an intractable problem, and we need a sustainable solution. But that's not all. For public health emergencies, we have to address research and development. We saw with the Ebola vaccine, we're seeing now with the Zika problem in the Americas. So we welcome the WHO pooled R&D fund that is housed within the Special Program for Research and Development. This is a global blueprint for R&D that is meant to help us with preparedness and rapid research response. So it will be helpful for the future, but it will also help us avoid some of the problems we've witnessed with Ebola and Zika. So we need bold solutions for the problem of new drug development. The first, you might have heard that there's a triple P approach, a push, pull, and pooling for tuberculosis. Let's find a mechanism by which we can finance R&D activities through innovative financing. We've seen innovative financing through airport tax. We can look at some other mechanisms through granting, but also incentive schemes that can be explored, particularly for tuberculosis. We can try it with one disease, see how it works, and expand on that and improve on that. But again, patent pooling. There's been debate about patent pooling. For some of the work that has been done in other areas, in the electronic industry, In the aviation industry, patent pools have been shown to work in dealing with patent thickets. We can test the idea in R&D for tuberculosis. We can look at whether de-linkage can be tested as a concept for antimicrobial resistance. In the de-linkage model, companies would be rewarded for R&D by other means. But this also removes the incentives for industry to boost sales in ways that encourage overuse and misuse. For antimicrobial resistance, we don't want to increase consumption. We don't want more people using antibiotics. But it's not an incentive for industry. But what other incentive mechanisms are in place? We may look at the concept of de-linkage, particularly for antimicrobial resistance. We've seen patent pools work. We've seen patent pools being used, and we'd like to see them expanded beyond the geographical scope. On an HIV treatment, they can be held by different holders, making it difficult to develop a pill that brings together various active ingredients. But licensing can be a way to address this challenge by pooling all patents needed for developing more affordable combination pills. We will recommend that it be considered for pediatric formulations, for instance, or for fixed dose combinations. South Africa has just published a policy for consultation on IP, which addresses a number of provisions that are in the TRIPS agreement. And this will introduce concepts like substantial search and examination, as well as patentability criteria, which involves inventive steps, novelty, as well as industrial application. We have never considered those criteria in the past. But there are also provisions that deal with patent oppositions, disclosure, voluntary licensing, and compulsory licensing. There are opportunities, firstly, in that the Sustainable Development Goals that was adopted refers to the principle of universality, which means as we address universal health coverage, it means we should also deal with treatment for all in all countries. The ambitious targets of 1990 will not be achieved unless we come up with innovative approaches of R&D. I've cited those three. Let's consider, firstly, de-linkage for antimicrobial resistance. Let's consider patent pools for pediatric formulations. Let's consider for AMR, de-linkage, and patent pools for pediatric formulations, as well as fixed dose combinations. Recognition and momentum around new models to drive innovation for certain diseases can also be considered. But I think we need to prioritize which areas need focus, what financing mechanisms should be explored. Let's use some of those things that work. Unit aid is one example, but there are a few others, particularly for AMR. There's a lot of momentum around AMR drug development. The EU has initiated a process. There is GARD that has been established. So WHO has also established an innovative idea in partnership with DNDi and the private sector. So when we look at those innovative ideas and we come up with some mechanism of coordination, it will not only strengthen our innovative capacity, but it will also improve access. The issue of IP has been a very difficult area that involves fierce debate and dialogue. But I think we need to find a mechanism, and an opportunity exists through the high-level panel that can help us at least acknowledge that each and every one of us can make a difference in finding solutions, that the welfare of each of us is the welfare of all of us. So let's not miss the opportunity of Durban 2016 to deliver on these commitments. We acknowledge that each and every one of us is intimately and inextricably of this earth, with its beauty and life-giving sources. Our lives are both enriched and complicated by what we have contributed ourselves. And in this particular conference, whatever our contributions are, will make a difference. I thought I needed to say, Mandela spoke about the long walk to freedom. I say the long journey towards access can be shortened for the benefit of those in need. And that shortening can involve those ideas that are floating. I just lifted the 3 that are practical: for AMR, for MDR-TB, and the use of patent pool for pediatric medicines. I thank you.
Please welcome back Dr. Lourdes